Hello, everyone. Kindly confirm whether I'm audible or not. Yes. So, a very good evening, everyone. This is Priyadarshini, your faculty for adult health nursing. I welcome you all for the prediction series of adult health nursing under your Plan C plus Platinum English edition. And this video is exclusively for the English audience and for my dear Plan C plus English subscribers. So, what is this series is about? Right, that will be the primary question when a session is coming in the last minute, right? So the thing is, prediction series, which means the MCQs, which has the higher chances or higher probability to appear in your upcoming prelims examination, or listed properly or compiled properly and made as the series called prediction series. So here you're going to discuss one of the most important MCQs which is coming under your adult health nursing, and also including we are going to deal about the recall MCQs of your NORCET 8.0, right? And we will wait for 5 to 5. We will wait for 5 minutes and let the others also join, and we will start. Yes. Yes, let people join. Let us start with the first MCQ. Yes, very good evening, Uma. Very good evening. Yes. Shall we start? I hope everything is fine. We will start. So the first MCQ which you're going to discuss is the graft. The graft from identical twins is called as what kind of graft? Yes, I want the people to answer in the chat box. And the most important thing is, this is the last minute series. So you people have might have had the complete revision or the complete studies has been over. And in this period, it is a time for quick recap and revision. Right? So here you people should enthusiastically answer me like what is the answer? And that energy I should able to analyze those energy. So I want everyone to actively answer. A very very good evening, Mova, Uma, Ankita, Shruti, everyone. Yes, yes, a very important question. These are basic questions, but they are tested in competitive examination. So the graph from identical twins is always called as isograph. What does mean by identical twins? Now tell me what does mean by identical twins. Identical twins or monozygotic twins. Monozygotic twins who are completely identical. And the most important thing you have to remember is when there is a transplantation or transfer of tissue or organ which is happening between an in the form of isograft between the two identical twins, here the immunosuppression therapy is not that much essential. Why? Because the histocompatibility, the antigen response, everything will be similar. So here there will be no immunosuppression is that much required in this case of isograft. Now tell me in the comment box what does mean by allografting. Now tell me in the comment box, what does mean by allografting? Allografting is exactly what is allografting is. It is like the transfer or the transplantation happening between two non-identical people. Okay, two genetically different people. Genetically different people. But what is the most important thing? They are from same species. They are from same species. For example, if I'm giving my organ, a tissue or whatever to my sister, okay, she is a genetically different person and or an another people, right? So that is termed as your allografting. What does mean by autograft? Yes. What does mean by autografting? Autografting is what Uma is telling. What is meant by autografting? One side to another side, one side to another side to a same person, one side to another side to a same person. So in case of any form of burns or any form of injury, so we are performing autografting. Allografting is two genetically different people. Either I am transplanting to my sister or to another different individual, that is termed as allografting between two individual people who are not genetically identical. And what is meant by autografting? I myself transfer my own tissue in and around my body to my within my body. That is termed as autografting, which means transplantation happening within the body. Then isografting between two identical twins, which means they are monozygotic twins. They are two identical twins. What is meant by xenografting? Yes, xenografting is between transplantation which is happening between different species. Different species. For example, the heart valve transplantations of the pig and materials of any form of animal products is used in grafting or for any form of treatment prophylaxis, that is termed as xenografting. So most commonly this xenografting is used in which era, in which cases is experiential xenografting. For example, to if we want to conduct any form of randomized control trials where we are testing animal tissue or cells with human compatibility, at that time this experiential xenografting is done, right? So this is very, very important. Allografting, two genetically different people, the transplantation or tissue transplantation is happening. Autografting, on the same site between the same person is happening. And isografting, monozygotic twins, that is a genetically identical twins. And xenografting is between two different species. So now the next question for you is, a patient with acute kidney injury, okay, acute kidney failure, becomes confused and irritable. Please note it, becoming confused and irritable. What is most likely the cause of this behavior? A patient is a case of acute kidney failure and he is exhibiting the symptoms of confusion and irritability. Now answer in the comment box, what is most likely the cause of the behavior? First is, if you talk about hyperkalemia, whenever the question is stating hyperkalemia, always remember there will be cardiac abnormalities. there will be cardiac abnormalities. The patient might exhibit any kind of arrhythmias. Like the classical feature of hyperkalemia is what? What is the classical feature of hyperkalemia? Put in the comment box. The classical feature of hyperkalemia. These are very, very important questions which will be asked in your examination. Now tell me, what is the classical feature of hyperkalemia? ECG findings of hyperkalemia. Yes, it is your tall peaked T wave, wide QRS. See, these questions are very, very, very common in your NORCET examination. So these things you should be very, very clear. So whenever you think about hyperkalemia, but if you ask me a question whether this hyperkalemia will be coming in acute kidney failure or not, obviously the patient will be exhibiting a, yes, very good, Moba. Obviously the patient will be exhibiting hyperkalemia in case of acute kidney failure. But here the symptoms of confusion and irritability is not closely related with your hyperkalemia. Next, we're going to talk about hypernatremia. Now tell me, hypernatremia will be the answer or not? Some people are answering hypernatremia, but the most important thing you have to remember is when the patient is having an acute kidney injury, there will be poor excretion. There will be poor excretion. When there is a poor excretion, what is going to happen? There will be excessive fluid accumulation. Excessive fluid accumulation. So this fluid accumulation is going to cause, on the other hand, hyponatremia. To be very specific, it is going to cause dilutional hyponatremia. So dilutional hyponatremia, in what other conditions you are seeing? You have to answer me. Dilutional hyponatremia, in what other conditions you are seeing dilutional hyponatremia? Now you people have to answer me in the comment box. Yes, please give a big round of applause to Ankita. She has answered correct. Like increased blood urea nitrogen will be the correct answer. Coming back to the distractor explanation. So the patient will be having dilutional hyponatremia, not hypernatremia in case of acute kidney injury. This is very, very important to note. And limited fluid intake. Obviously, we will be asking the patient to have a restricted fluid intake. This is one of the primary management which we are instructing for the patient, to have a reduced fluid intake during the time of acute kidney injury. The patient will go for dehydration. Because of that, they could not have this much neurological symptoms such as confusion and irritability. Right. So limited fluid intake will also not be the correct answer. The correct answer is your increased blood urea nitrogen. For the people who are answering, yes, Uma, very good. It is SIDH, where the classical feature is your dilutional hyponatremia. Right. Now tell me, increased blood urea nitrogen is the correct answer, which is causing confusion and irritability. What is the rationale behind it? Why it is causing confusion and irritability? See, acute kidney failure is a condition where there is an improper excretion of the metabolic waste materials, right? So here what will happen? All the blood, urea, and all the metabolic components are going to accumulate inside the body. This accumulation is otherwise called as your azotemia. So because of this azotemia, this elevated blood urea nitrogen is going to cross your blood-brain barrier. It is going to cause your blood-brain barrier. Thereby, the patient will be going for uremic encephalopathy. Agree with my point? The patient will be going for uremic encephalopathy. Agreeing with my point, thereby the patient is going for uremic encephalopathy and possessing this neurotoxic effects such as your confusion, lethargy, irritability, decreased attention span, restlessness, seizures. All these conditions will be coming for the patient who is going for uremic encephalopathy influenced by your acute kidney injury. Right? So we will see the next question now. Yes. Now tell me, this is a GCS related MCQ. These questions are very, very common in your examination. Now you're going to answer me so clearly. What is the answer? A 32 years old male patient suffered a head injury due to an RTA, that is your road traffic accident. He couldn't talk and made some sounds. He couldn't talk, but he is making some sounds, which is indicating the patient is making incomprehensible sounds. Incomprehensible sounds. Right? So the patient is making incomprehensible sounds. He opens his eyes to painful stimuli. He opens his eyes to painful stimuli and localizes it, which means he is opening the eyes for painful stimuli and he can able to localize it also. So which is indicating the patient is opening eye response for painful stimuli and the patient can able to localize pain also. Now tell me, what is the scoring? So let's go to the Glasgow Coma Scale and we will recap. And the most important thing is many people have started answering correctly. That is very, very nice. Muva, Uma, very good. Very good. You people are going to clear this time, I think. Yes, definitely. Yes. So here we are going to see, look up to this. So first is eye-opening response to pain. So the scoring will be eye-opening response to pain. So the scoring will be 2. Yes, it is E2. And the verbal response, the patient was exhibiting incomprehensible sounds. So the response, the scoring will be 2. And the patient can move for localized pain, right? The patient can sense pain in the eyes and he can localize the pain. So if he is going to move to localize the pain, the score is 5. So now tell me, what is the scoring? It is your E2, V2 and M5, right? So the total score is 9. So the answer will be D. Am I right? Yes, yes. So let's quickly go to the next question. Before that, I would also like to reinforce the important findings of your GCS. So what is the important findings? The best response is 15 out of 15. And the comatose client, when we are terming the patient is a comatose client, when the score is 8 or less, and totally unresponsive, even though the patient is totally unresponsive, the most minimal score is 3 only. It is not 0. That also you people should definitely remember. It is not 0. Even though the patient is totally unresponsive, the score is going to be 3. Right? So next is another important question. A person is brought to emergency after bee sting, after a bite of a bee sting. So he have hives all over his body. So if the patient is going to have hives all over the body, what does it is indicating? It is indicating the patient is having some anaphylactic reaction. Anaphylactic reaction. Right? So the pulse is low. The patient pulse is of low volume and the BP, sorry, the pulse is low volume and the pulse is 110 per minute and the patient is having cold clammy extremities with BP of 70 by 50. That is your hypotension. So, and the patient is also exhibiting peripheral cyanosis and auscultation shows bilateral conducted sounds with rattling of secretions, with excessive secretions. GCS is 12 out of 15. The patient is quite responsive. And which of the following is correct about this patient? Which of the following is correct about this patient? Now I want you people to answer so cautiously. I hope the screen is so visible. Since we have diagnosed the patient is going for bee sting bite, and he's going for anaphylactic reaction where we are evidencing the heaves all over his body. Now tell me what will be the correct answer in the chat box. Yes. A. Some people are answering A. I want the correct answer. See, children, always remember the dosage of adrenaline is so varying. Please be cautious. Here, In case of anaphylactic reaction, the adrenaline will not be diluted. So by that, you can able to easily answer this question. Yes. Ankita, please give her a big round of applause. The correct answer is D. Remember, adrenaline 0.5 mg. The important things you have to remember is, in case of anaphylactic reaction, the adrenaline which you have to administer is 0.5 mg. The route of administration is intramuscular. Remember, in case of IV only, the dilution is going to be 1:10,000. In case of intramuscular, to have a good effect, even though the drug is administered in intramuscular, to have a good effect, we are not diluting adrenaline, right? So the dosage is 1:1000. The dilution ratio is 1:1000, which means there is no dilution at all, which means 1 ml per 1 mg. The 1 ml ampule is having 1 mg of drug. As such, we are going to administer the drug. And since we have evidence the patient is going for hypotension, okay, and the GCS is quite deteriorating, that's why we are giving fluid stabilization to the patient. Yes, 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 Uma, very good. So that's why we are giving saline infusion for the patient. On the other hand, when you talk about intramuscular route, now tell me, what is the best site for administration of this IO injection? Now tell me, what is the best site for the administration of your IM injection in case of anaphylactic reaction? It is your anterolateral thigh. It is your anterolateral thigh. Right? Always remember, IM for anaphylaxis, adrenaline will not be diluted for IM injection. Right? Am I clear? Now let us recall quickly. Let's recall, like, what is the dilution ratio for all the cases when the adrenaline is administered. Yes. So now 1:1000. Now answer me, 1:1000 is for what are all the cases? For either subcutaneous or IM. Just now we have seen, in case of any form of anaphylactic reaction, we are going to administer this dilution. Or for endotracheal administration also, we are going to have this particular component of dilution only, 1:1000, right? Anterolateral is the most prominent route, dear. Okay, all the books are terming that anterolateral thigh is the most prominent site for administration of your adrenaline in case of any anaphylactic reaction. So next is 1:10,000. If you talk about 1:10,000, this is the dilution rate in case of your resuscitation and IV. Right, in case of your CPR, you're giving this rate only. In case of IV, in case of intraosseous. In case of intraosseous also, you're going to administer. So intracardial also, we have been administering for 1:10,000, which is not used right now. Right. So next is 1:1 lakh. Now tell me, 1:1 lakh is used in which cases? 1:1 lakh is used in which cases? Now you have to answer me. 1:1 lakh is administered in which cases? For local administration, for vasoconstriction, we are administering this particular dosage. And the last dosage you have to remember is 1:2 lakh. This is also administered for local purpose along with anesthetic medication such as your lidocaine. Right? So this particular information is very, 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 very important. Expecting one question from this particular table. Right? So for subcutaneous IM endotracheal, it is going to be 1:1000. To make, just remember the common sense. Like, I'm going to make the drug to absorb more. That is the common component which you have to remember here. 1:10,000 in case of IV while in the management of CPR in intraosseous administration, you're giving 1:10,000. So 1:1 lakh for local, and for vasoconstriction purpose, you're administering a very, very diluted form of adrenaline. 1:2 lakh for, or along with lidocaine, we are administering. So here 1 ml is equal to 1 mg. Here 1 ml is equal to 0.1 mg. Here 1 ml is equal to 0.01 mg. Right? Yes. Now let's go to the next question. You are in an operating room and you notice the tracing in the white color on the device. That is, your cardiac monitor is showing a white color tracing. So here you can see it is green color, it is yellow color. Here you have the white tracing. What does it indicate? Now tell me the answer. What does it indicate? The cardiac monitor is showing a white tracing. What does it indicate? Now tell me. What does it is indicating? Yes, very good. Please give a big round of applause to your Uma. Yes, capnography is the correct answer. Now tell me, what is capnography? Capnography is your... Now tell me, what is capnography? Capnography is your CO2 concentration during the respiratory cycle. So capnography is monitoring of the CO2 concentration during respiratory cycle. What is the primary component we are assessing in this? What is the most prominent component we are assessing in this? That is your EtCO2. I hope you all know about this particular term. What is EtCO2? Mention what is the importance of EtCO2. So EtCO2 is your end-tidal CO2. EtCO2 is your end-tidal CO2. This will be the confirmatory test for identifying the concentration of your, identifying the efficacy of your endotracheal tube placement. Right? Very good. CO2 concentration. So here, this end-tidal CO2 is the gold standard, tool to identify the endotracheal tube is placed properly or not, placed correctly or not. Right? This EtCO2 waveform will tell you, will be confirmatory for the placement of your endotracheal tube. In other cases also, for example, if the patient is going CPR, if the patient is done with CPR, in that case also, the most important thing you have to remember, the EtCO2 should be always maintained at 10 mm of Hg. Right? So if it is maintained at the minimum point of 10 mm of Hg, the prognosis will be good for the patient in case of CPR. Right? If it is going less than 10 mm of Hg, the prognosis is going to be very, very poor. And what is the next important thing? What is the normal EtCO2? Now tell me, what is the normal EtCO2? The normal EtCO2 is, yes, I want the answers. I want you people to answer. What is the normal EtCO2? Yes, I'm waiting for your answers. See, these kind of questions can possibly come in your examination. The normal EtCO2 is 35 to 45 mm of Hg. Remember this. The normal EtCO2 is 35 to 45 mm of Hg. On the other hand, airway pressure is not visibly monitored with the help of your cardiac monitor. Airway pressure will be usually seen in your ventilator setups. In ventilator waveforms where the PEEP, plateau pressure, everything is monitored, that will be visible in your ventilator. So O2 pressure in inhaled air. This is analyzed with the oxygen analyzer. And this is nowhere seen in the cardiac monitor. And at last, we have this O2 pressure in exhaled air. This is your what? This is your end tidal O2. But this is not monitored in your cardiac monitor. This white form is totally indicating your end tidal CO2. So now we will see the important findings of your ETCO2. First is, this is your capnographic waveform, as you can see. So the sudden loss of waveform, what sudden loss of waveform is indicating? The sudden loss of waveform is indicating either the ET tube is disconnected or dislodged or kinked or obstructed. The sudden loss of your EtCO2 is indicating that either the ET tube is dislodged, kinked, or obstructed, and loss of circulatory function. Next is decreased in EtCO2. Either if the patient is having the cuff leak or the ET tube is going into the hypopharynx and there is a partial obstruction, in those cases, the patient will be having what? Decreased EtCO2 level. And for CPR assessment, your ultimate aim, as I said, the ultimate aim is to maintain the minimum of 10 mm of Hg. While giving you CPR, the minimal amount, like this is one of the important component in the high quality CPR, right? You should attempt to maintain the EtCO2 level at 10 mm of Hg while the patient is on CPR, right? So sudden increase in EtCO2, which means while you're performing CPR and the EtCO2 is under 10 mm of Hg, and with an effective CPR, the patient is reverted. So the ROSC is done. That is, your return of spontaneous circulation has been attained. At that case, what will happen? There will be a sudden hike in the EtCO2 level. There will be a sudden hike in the EtCO2 level. Next is shark fin appearance. Shark fin appearance is seen in case of obstructive lung diseases such as your asthma and COPD, that is your chronic obstructive pulmonary disease. So here you can see the shark fin appearance of your EtCO2 waveform. So that is indicating your chronic obstructive pulmonary disease as well as asthma. In case of hypoventilation, you can see the widened waveform where the ventilation is happening so much reduced. So here in case of hypoventilation, you can see the widened waveform. On the other hand, in case of hyperventilation, you can see the rapid EtCO2 waves. Rapid EtCO2 waves. Decreased EtCO2 intermittently, which happens because of any form of apnea or sedative drugs. Any form of apnea or sedative drugs. So next, we are going to talk about the most important topic and most important question. So that is about your suture materials, right? So a 30 years old man undergoes an open appendectomy, and plain catgut suture. The key point is plain catgut suture is applied for the patient or used for closing the muscle layers. Which of the following statement regarding these suture is most accurate? Now tell me what is the answer in the chat box. Yes, Priyanka, very good, Priyanka. Your answer is absolutely correct. Yes. So whenever you see about catgut, it is an absorbable natural suture. It is a natural and absorbable suture. It is a natural absorbable suture. Chromic catgut is with a layer of a chromic salt, but it is not majorly used. But plain catgut is used in most of the cases. So primarily it is an absorbable suture. So primarily it is absorbed by enzymatic proteolysis. Obviously, your catgut suture is absorbed by the mechanism of enzymatic proteolysis. So this particular suture material, your catgut is derived from your sheep gut, and it is a natural absorbable suture. Now, the most important thing is it will be degraded by your enzymatic proteolysis. So how many days it requires for that enzymatic degradation? Now you have to tell me how many days the catgut suture will take for enzymatic degradation. Tell me absorption time. Now you have to tell me the absorption time of your catgut suture, as well as here you can see it has a variable tensile strength. Now tell me what is meant by tensile strength. The tensile strength, how much the suture can hold the tissue. That is termed as your tensile strength. How much time a suture can hold two tissues so prominently and properly is termed as your tensile strength. Now tell me what is the tensile strength as well as the absorption time of your catgut suture. Any answers? Any proactive students who are ready to answer for this question can readily answer in the chat box. See, the absorption time of your catgut suture is 21 to 28 days. The absorption time of your catgut suture with your enzymatic degradation is 21 to 28 days. A very, 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 very important MCQ point. Now, as I said you, it has variable tensile strength. What does it mean by variable tensile strength? The tensile strength can vary based upon the suture configuration, based upon the tissue, based upon the supply and everything. So that is termed as what? Your that is termed as your tensile strength. So the tensile strength, see, please remember the absorption, the tensile strength. See, please remember. See, the tensile strength is 21 to 28 days. Sorry, I was confused. The tensile strength, tensile strength of the suture is 21 to 28 days. Okay, it has an effective tensile strength, and this may vary because of any form of mechanical activity or anything like that. But the absorption time is 90 days. Please remember this point, ignore the previous point. Please remember this point. The absorption time is 90 days, whereas the tensile strength is 21 to 28 days. Remember, the absorption time with enzymatic proteolysis is 90 days, whereas tensile strength is 21 to 28 days. That is what you have to remember definitely. Now tell me, let's have a quick review on the classification of sutures. Yes. See, absorption time by enzymatic degradation is 90 days, dear, with a standard book reference I'm telling you. And the tensile strength is for 21 to 28 days. Now tell me, under natural absorbable, you have this. Under natural. So first we will see absorbable suture. Right. So absorbable suture, natural and synthetic. Natural and synthetic. Right. So under natural only, we have this catgut and chromic catgut. So we have discussed clearly about catgut, what are all the components which is coming. Right. So now tell me, what are all the synthetic absorbable sutures? A very, very important point you have to remember. What are all the synthetic absorbable sutures? The synthetic absorbable sutures, which includes your monocryl, your vicryl, and your PDS. What is the expansion of your PDS? That is your polydiaxone. Very good. Polydiaxone. Right. That is your polydiaxonone. Right. So this or synthetic suture. On the other hand, we are talking about non-absorbable sutures. So non-absorbable sutures. So natural and synthetic. So what are all the natural non-absorbable suture? That is, the best example is your silk. The best example is your silk. On the other hand, when we talk about synthetic non-absorbable suture, very good, Uma. Synthetic non-absorbable suture, it is your Prolene. It is your Prolene and nylon. Prolene and nylon. Right. So what is the most important point you have to remember for exam point of view is which particular suture causes more tissue reaction? Now I am asking you the question. Which suture material causes increased tissue reaction? Increased tissue reaction or inflammation? I'm waiting for your answers. Now you have to answer me. So either natural sutures or synthetic sutures is going to cause more amount of tissue reaction or inflammation. That is what is my question. Yes, polyfilament, that is braided sutures. For example, if you talk about Vicryl, a very, very important point, Mr. KP, very good, polyfilament. Can you give me the example for polyfilament, dear children? See, the most important exam specific MCQ you have to remember is, if you talk about Vicryl, it is a braided suture. It is a braided suture. So what this is going to do, this will be having n number of thread layers. This braided suture is going to have n number of thread layers. Because of that only, this is having increased infection rate. This is having increased infection rate. Right. But my question is, which suture causes increased tissue reaction and inflammation? Infection is higher in case of your braided suture, as you people were telling, right? But my question is, which suture is going to cause increased tissue reaction? So here you people are rejecting, right? Causes minimal tissue reaction and are preferred for patient with suture allergies. So here itself the answer is present. As since we are rejecting this as a distractor, the most important point you have to remember is, whenever there is a question which is stating which suture causes increased tissue reaction or inflammation, that is always natural sutures. That is always natural sutures. Natural sutures has increased tissue reaction and inflammation when comparing to other sutures. But as you people were telling about Vicryl, braided sutures, multi-filament sutures, remember about your Vicryl. This Vicryl is going to cause increased infection rate, is having the risk of causing increased infection. That you people have to remember. Right. Yes. Very good. So remember this point in that, and any other important point you have to know is your PDS. Any answers like what is the absorption time for PDS? Absorption time for PDS. Yes, I'm waiting for your answers. PDS is also a monofilament suture. Monocryl is also a monofilament suture. These are very commonly asked in examination. Now tell me absorption time. The absorption time is 180 days in case of your PDS. Right? So this is again an important MCQ point you people have to remember. Remember it. Right? Yes. Now we will go to the next question. Yes. An ABG question. Now quickly answer me. And let's see who is very good in ABG. A 60 years old man with a history of chronic obstructive pulmonary disease. Primarily, if you see the condition, the patient is a case of chronic obstructive pulmonary disease. The patient will be having what condition? The patient will be having hypoventilation. Right? So with that itself, you might have come with a conclusion, but I want you to see the ABG also to support your diagnosis. Present with increased shortness of breath. His ABG analysis is shown what is most probably the underlying acid-base disorder. Yes, now answer me. Yes. Very good. Respiratory acidosis is the correct answer. See, whenever you see any form of ABG question, just write the normal values on the one side and you have to analyze it. Right. Very good. Very good. See, B is not the correct answer. Respiratory acidosis. Like, I hope many people have watched the videos of ABG. See, always remember how to interpret an ABG. First is you have to watch the pH and PCO2 level. Right. If pH and PCO2 are going in same direction, pH and PCO2 are going in same direction. If pH is increasing, PCO2 is also increasing. If pH is decreasing, PCO2 also decreasing. Always remember same YAM, and it is a metabolic problem. It is a metabolic problem. It is a metabolic problem. On the other hand, when the pH and PCO2 are moving in reverse direction, remember reverse R, and the patient will be for respiratory problem. The problem is respiratory. If the pH is increased, it is alkalosis. If the pH is decreased, it is acidosis, as you all know. Right? So with the same basic rule, simple rule, we are going to learn how to interpret this pH. So the pH is 7.24. The normal pH is 7.35 to 7.45. So the pH is decreasing. So it is a case of acidosis. The PCO2 normal value is 35 to 45. Since the patient is a case of COPD and he is having hypoventilation, this hypoventilation is going to proceed the patient to go for excessive CO2 accumulation, which is going to cause increased level of CO2. So what is happening? The PCO2 is increasing. So coming back to the basic rule, if the pH and PCO2 is moving in reverse direction, it is a respiratory problem. And since the pH is reduced, it is acidosis. So we are coming to the conclusion the patient is going for respiratory acidosis. Right? And the most important thing you have to remember is about hypoventilation. Whenever you see a condition of hypoventilation, you have to remember the patient will go for CO2 accumulation. CO2 accumulation inside the lungs. CO2 will be stored as carbonic acid. CO2 will be stored as carbonic acid. So what is going to happen if carbonic acid is excessively accumulated in the body? This is an acid component which is going to increase the acid level. So that's why the patient is going for acidosis. On the other hand, if you talk about hyperventilation, let me use a different color so that you will have a better understanding. If the patient is going for hyperventilation, so if the patient is going for hyperventilation, what is happening? There will be CO2 washout. If I'm keep on doing the respiration so rapidly, so what will happen? There will be CO2 washout. If excessive CO2 is washed out, the acid component, the carbonic acid is an acid component which is happening because of CO2. So that is lost. So the patient will go for alkalosis. The patient will go for alkalosis. These are the very, 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 very important rule you have to remember before attempting any kind of ABG related MCQs. So the patient is already a case of chronic obstructive pulmonary disease and he's going for hypoventilation. So that's why we are diagnosing the patient as a case of respiratory acidosis. Very good, Muva. I hope you understood now. Yes. So the next question, an ECG question. ECG questions are most expected for your examination. Okay. So now tell me, a 70 years old man with a history of ischemic heart disease present with palpitation for last 3 days. A transesophageal echo shows a thrombus in the left atrium and his ECG is shown below. Which of the following should be done to treat his condition? Now tell me what is the answer. Very good, Priyanka Patra. It is an initiating an anticoagulant therapy. Now tell me what is the ECG which is given here. Read out the ECG. What is the ECG finding which is given? What is the diagnosis of the ECG? What is the diagnosis of the ECG? Yes, dear. Yes, Moga. What is the diagnosis of the ECG? See, you should be very clear in the ECG interpretations. I think Plan C plus subscribers had the access for fast track English. There, all the ECG was explained one by one. Now tell me, what is this ECG? Very good. Koshesh Sharma, Uma, very good. It is atrial fibrillation. It is a case of atrial fibrillation. It is AFib. And the most important thing is, what are all the classical ECG findings of AFib? The patient will be having irregular rhythm. Irregular rhythm. Along with that, there will be absence of P wave. There will be absence of P wave. Along with that, yes, absence of P wave. Right? So since atrial, if you have watched the fast track lectures, you should be very clear that the most important condition which is closely associated with atrial fibrillation, right? The important condition which is closely associated with atrial fibrillation is what? Is your thrombus formation. The patient will be, because of excessive fibrillatory waves, there will be thrombus formation. If it is not treated properly, the patient will proceed for stroke. Right. So first and foremost action is to initiate the anticoagulant therapy. Now tell me, what is the drug of choice? What is the drug of choice in the prophylaxis of starting an anticoagulant therapy for a patient with atrial fibrillation? What is the drug of choice? Yes, I want the active students to definitely answer for this question. It is an important pharmacology question as well. Now tell me, what is the drug of choice when the patient is going for atrial fibrillation with the risk of this transesophageal thrombus findings in the left atrium and all? The drug of choice, always keep it in your mind, it is warfarin. It is warfarin. And the most important thing you have to remember is, as I said you, the drug of choice is warfarin. We use two drugs. One is warfarin, and also we use direct acting oral anticoagulants. Direct acting oral anticoagulants. Under your direct acting oral anticoagulants, okay, and under your direct acting oral anticoagulants, you have two particular classification. That is your DTI. That is your direct thrombin inhibitor. Now tell me, what is the example of the drug? That is your dabigatran. And we also have factor 10A inhibitors. Both are administered in oral route only. Factor 10A inhibitors, which includes your apixaban. Tell me, apixaban, your endoxaban, and your rivaroxaban. So direct thrombin inhibitor, that is your dabigatran, and oral 10A inhibitors, that is your apixaban, rivaroxaban, and your endoxaban. So as I said you, this is inhibiting factor 10A. What about warfarin? Warfarin reduces factor what are all the factors warfarin is reducing? Warfarin will reduce factor 2, 7, 9, and 10. It reduces factor 2, 7, and 9, and 10. Last, it will reduces 2 and 7. First, it will reduce 9 and 10. Another important MCQ point you have to remember is, what is the antidote of warfarin? What is the antidote of warfarin? Obviously, your answer will be vitamin K, right? But the most important additional points you have to remember is your 4-factor prothrombin complex. Your 4-factor prothrombin complex. And your FFP, fresh frozen plasma, is also one of the important anticoagulant for your warfarin therapy. Is also one of the most important anticoagulant for your warfarin therapy, right? So now tell me, for direct acting oral anticoagulants, what are all the... Yes, very good. Yes, very good. Along with vitamin K, please remember about 4-factor prothrombin complex and your fresh frozen plasma. If options are indicating this 4-factor prothrombin complex and fresh frozen plasma, you people have to answer this also. Do not search only for vitamin K. Very good, Priyanka. Very good, Uma. Very good, Priya, Ankita. Very good. Right. So very good. I'm so happy for you all. And now tell me, critically analyze the question which I'm asking. For direct thrombin inhibitor, dabigatran, what is the antidote? What is the antidote? Antidote is your idaruxizumab. Your idaruxizumab. That is the antidote for dabigatran. Whereas for your factor 10A inhibitors, apixaban, endoxaban, and rivaroxaban, the antidote is adenexate alpha. It is your adenexate alpha. So this is again a very important question you people have to definitely remember for going for your NORCET examination, right? Yes. So with that, we are going. So whenever the patient is going for any form of thrombus formation, in case of atrial fibrillation, your primary response is to initiate the anticoagulant therapy. Always remember the drug of choice is warfarin, but along with that, we are giving other drugs also, direct acting oral anticoagulants, which includes your direct thrombin inhibitor, that is your dabigatran, and your oral factor 10A inhibitor, that is your apixaban, endoxaban, and rivaroxaban. The most important thing is, warfarin is the primary prophylaxis and drug of choice that you people have to definitely remember. That too, the patient is having, and even though the patient is having a prosthetic valve, in case of atrial fibrillation, this will be the drug of choice. For native valve, we are using these drugs. For native valve or no valve, we are using these drugs. That is also a very important additional point you people have to remember. All right. So let's go to the next question. A patient was brought to emergency. Room following a road traffic accident. You notice that the emergency physician uses a trauma scoring system, which involves the energy of the injury as one of the component. The key point which they have given is the energy of the injury. As one of the most important component for a patient with a road traffic accident. You have noticing the emergency physician is doing a trauma scoring system, and he's primarily accessing the energy of the injury as one of the most important component. So which of the following trauma scoring system is used here? Now I'm waiting for the answer. Yes, yes, yes. Come on. I'm waiting for the answer. Priyanka, very good, dear. It is your mangled extremity score. It is your mangled extremity score. Whenever you study about mangled extremity score, always remember about ELISA, a short mnemonic, that is ELISA. So what is ELISA? What is ELISA? E stands for energy. Okay. E stands for what? E stands for energy. Energy of the injury. Energy of the injury. So what is meant by energy of the injury? The injury may be a very strong. For example, low stab injury. Okay. Low energy stab. High energy stab. Okay. Or crush injury. So everything is termed in case of your E. L and I in combined termed as your limb ischemia. Limb ischemia. And S stands for shock. S stands for shock and A stands for age. Is another component which is assessed in case of your mangled stroke. So mangled score is a specific score which is specifically assessing the energy as well. So here in rest of the score, for example, injury severity score. What this injury severity score is analyzing? So anatomical injuries, the anatomical location is given more importance in this. Okay, injury severity score is indicating the anatomical location of the injury. Anatomical location of the injury. Revised trauma score. What is revised trauma score is indicating? It is the combination of your GCS. It is the combination. This score is the combination of your GCS, your systolic blood pressure, and your respiratory rate. And trauma and injury severity score is the combination of this both. Is the combination of this both. Both your injury severity score, revised trauma score is the combination of this trauma and injury severity score. But here you have to remember mangled extremity score is the only score which is stating about the energy of the injury. That is the only score which is stating about the energy of the injury. So whenever you see a term like which is indicating energy, you have to think about mangled extremities severity score. And you have to remember about ELISA, which is energy of the injury, limb ischemia, shock, and age. Next is injury severity score. Injury severity score is indicating about the anatomical location of the injury. Next is revised trauma score. Revised trauma score is indicating both your GCS, BP, and respiratory rate, or the components which is coming under your revised trauma score. And trauma and injury severity score is indicating the combination of both your B and C option, that is your injury severity score and your revised trauma score. Right? So next, we will go to the next question. Which of the following is a clinical feature or seen in Parkinson's disease? Now you have to tell me the primary clinical feature which you are seeing in the Parkinson's disease. Answer me immediately, because this is a very, 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 very simple question. It is a very, 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 very simple question. Anosmia. What does it mean by anosmia, dear children? Absence of smell. Absence of smell. Anosmia means absence of smell perception. Again, this is going to be the 145. Please give a big round of applause to Priyanka Patra. That is the correct answer. Absence of smell. Very good. Loss of smell or absence of smell. That is a late finding, non-motor finding of your Parkinson's disease. Intentional tremors is not seen in case of your Parkinson's disease, whereas your resting tremors are seen. What are the resting tremors you can see? Pill rolling tremors. Pill rolling tremors. Now tell me, in what are all the cases we can see intentional tremors? Any form of cerebellar lesions. You can see the patient is having intentional tremors. But here in Parkinson's, it is always resting tremors. Resting tremors. Visual hallucination will not happen, but when the patient is going for drug therapy such as levodopa or carbidopa, at that time in late cases, the patient will get this what condition? That is visual hallucination. Asymmetrical rigidity, a very important finding which you can see in patients with Parkinson's disease, and bradykinesia, slowness of movement, which is a classical feature of your Parkinson's disease. Right. Along with that, your patient will be having rigidity, and your patient will be having non-motor features such as anosmia, constipation, depression, sleep disorders, and all. Right. Along with that, the patient will be having postural instability, right, later in the future. So the correct answer is 1, 4, and 5. Let's quickly go to the next question. A 58 years old man present to an emergency department with acute onset of severe abdominal pain and distension. On abdominal X-ray is performed, showing free air in the peritoneal cavity. Remember, this is the key point. X-ray is showing free air in the peritoneal cavity. Which of the following sign represents free air outlining the lateral umbilical ligament? So these are remembering, like memory-based questions. Remember, whenever they are telling free air in the peritoneal cavity, which is outlining the lateral umbilical ligament, then the answer will be inverted. V sign. This inverted V sign is a classical feature which you can see in patients with pneumoperitoneum, specifically where in the fluid is accumulated in the lateral umbilical ligament. On the other hand, you have other things. Ligamentum sign. This ligamentum sign will be seen in case of free air outlining the round ligament of the liver. Free air outlining the round ligament of liver. So here it is completely inverted V sign is completely talking about your lateral umbilical ligament. And next is your stellate triangle sign. Where stellate triangle sign will be seen? That will be seen in the bowel loops. And dog cap sign will be seen in which area? Dog cap sign will be seen in the subdiaphragmatic triangle. Subdiaphragmatic triangle. Subdiaphragmatic triangle, that you have to remember. So here you can see this inverted V sign. That is indicating the lateral umbilical ligament air spaces swelling. So next, now tell me the important question again. A 28 years old male present to clinic with complaints of recurrent palpitation. You want me to go fast or little bit slow? Let me know. Recurrent palpitation and lightheadedness. On ECG was taken and he was diagnosed with Wolff-Parkinson-White syndrome. What are all the ECG features you can see in Wolff-Parkinson-White syndrome? A very important question. Classically, tell me what are all the ECG findings you can see in case of your Wolff-Parkinson-White syndrome? Yes, come on. Many people are answering B. Is that really correct? Analyze properly. All the bright students as well. Analyze properly and tell me. Analyze properly. What ECG changes are seen in this Wolff-Parkinson? Yes. First and foremost is you can see a narrow QRS complex. And sorry. See, Always remember, in Wolff-Parkinson syndrome, always you can see a wide QRS complex, not a narrow QRS complex. So this is rejected. You will not see a narrow QRS, you will be seeing a wide QRS. Obviously, the patient will be having a delta wave. What is meant by a delta wave? You can see the slurring in front of the QRS complex. You can see this is your slurring of the QRS complex can be seen. Slurring of your QRS complex is seen. That is termed as your delta wave. That will be present in case of your Parkinson's disease. So the next is the patient will be having a short PR interval or a long PR interval. The patient will be having a short PR interval or a long PR interval. The patient will be having a short PR interval. So the answer will be 2 and 3. So for a quite confusion, I have done for the students, but they were very clear, very good. So the findings you can see is your delta wave and your short PR interval. So the option B is correct. So the patient will be having a wide QRS complex, not a narrow QRS complex, and the delta wave will be seen. The PR interval will be short. Now put me in the comment box. What is the normal PR interval? What is the normal PR interval? Normal PR interval. The normal PR interval is 0.12 to 0.20 seconds. So in case of your Wolff-Parkinson syndrome, it will be less than 0.12 seconds. On the other hand, the patient will be having a wide QRS, right? The patient will be having a wide QRS. So now tell me, what is the normal QRS duration? Normal QRS duration is 0.08 to 0.12 seconds. So if it is wide, it is going to be greater than 0.12 seconds. This also you people have to note. Very good, very good, very good, very good, very good. Yes. So now we will go to the next question. And here you can see the ECG findings. So here, this is the delta wave slurring of the QRS, starting point of the QRS, and PR interval will be short. The QRS complex will be long. So that is what we have to note. So now we'll go to the next question. Which physician order should the nurse question for newly admitted patient diagnosed with diabetic ketoacidosis? As a nurse, for what particular intervention you will be interrupting and asking a question for a patient newly admitted with diabetic ketoacidosis? Yes. I'm waiting for your answers. Very good, Priyanka. Dextrose 5% in water at 125 ml per hour. Already the patient is a case of diabetic ketoacidosis where the patient will be on hyperglycemia. Dextrose will be indicated after an insulin therapy. If the patient is going for hypoglycemia, then only we will be instructing the patient should go for a dextrose, or else we are not strictly administering any form of dextrose to the patient. Right. So potassium chloride 10 milliequivalent in 100 ml normal saline. It is an definitive management which we are doing for the patient with diabetic ketoacidosis. Start atrial blood gas analysis, administer soda bicarb. Soda bicarb also, when you have to administer, that is also very important. Whenever the pH is going to be less than 6.9 or 7, only you're going to administer soda bicarb, or else you're not going to administer soda bicarb. That you have to definitely put in your mind. So regular insulin per protocol and adjust dose based on hourly glucose levels. So this is again a very, very important management, right? That is an abrupt mainstay management, administration of insulin. Why we are administering potassium chloride, you all know what is the reason behind it. So these three will be your definitive management, but 5% dextrose should not be administered until if the patient is going for any form of what? Until the patient is going for hypoglycemia, we are not administering dextrose, right? So we'll go to the next question. Yes. So diabetic patient sustains a fall. A diabetic patient sustains a fall. Since he is not able to talk properly, NCCT head was done to the patient. What is the best step in the management of this patient? So here you can see the NCCT of the patient. Now tell me, what is the finding of the NCCT? What did you see in the NCCT? You can see the hyperdense area within the lung parenchyma. You can see the hyperdense area in the brain parenchyma. On the other hand, you can also see, what? Shift. Okay, and this is a case of ICH. That is your intracerebral hemorrhage. That is your intracerebral hemorrhage. So for intracerebral hemorrhage, okay, for intracerebral hemorrhage, what is the primary management? What is the answer you people are giving? Mannitol. Obviously, mannitol will have an effect that it is going to reduce the intracranial pressure. We can give mannitol, but it is a primary management? Vitamin K and FFP we can give in case the patient is having any form of coagulopathy. At that case, we are giving. But here, nothing is indicating that. What is the best step in the management of this patient? That is what the question is telling. You have to answer that. What is the best step in the management of this patient? Thrombolysis with streptokinase. Already the patient is having an intracerebral hemorrhage. We should not administer any form of thrombolytic therapy. This is going to further worsen the bleeding. Just remember, before administering mannitol, you have to stabilize and do a neurosurgery consultant. Inform the patient. Mannitol therapy all will be done after the information to the patient, information received from the doctor only. Right. Very good, Shiva. Very good, Shiva Parameshwari. Very good. Stabilization is first. Very good, Priyanka. Stabilization of the patient is first. You have to stabilize, and you have to inform the neurosurgeon, and you have to stabilize the patient. That is the primary response. Later only the intervention will be coming. Analyzing and stabilizing is the first thing. Right? In some other cases, in some other questions, what will be there? First is intervention, next is reporting. So based upon the question, you have to able to analyze and do the marking of your answers. Don't mark just like that. So for your better understanding, I have put this other CT findings also. Right? So you people will never miss these questions in your examination. Right? So first is in case of contusion. So in case of contusion, what you can see? In case of contusion, so the bleeding will be inside the brain, which we have seen in the previous question. And you can see the edema of the brain parenchyma will be present. And this is because of brain injury. Either it is a head injury, corp or counter corp. You all know corp means directly hitting on the direct injury at the location of the injury, and counter corp is to the opposite direction the injury is happening. That is counter corp. Right. So key features: patient will be having seizures and focal signs. So biconvex, remember, whenever the patient is having a biconvex lens shape kind of in CT findings, you have to remember it is an epidural hemorrhage. It is an epidural hemorrhage. Always remember it is an epidural hemorrhage. So biconvex shape is always what? Epidural. Biconvex shape is always epidural. Remember that. There will be no edema. And this is because of your middle meningeal artery rupture. That is again an important MCQ point you have to note. This happens when there is a skull fracture, especially temporal bone fracture, right? And this happens with lucid intervals. The patient will be talking nicely, and suddenly after recovery, the patient will be talking. That is termed as a lucid interval. Initially, the patient will be on unconscious. Later, he will be going for lucid interval where he will be very conscious and he will be talking. Later, what will happen? The patient will be going for sudden deterioration. That is termed as lucid interval. Lucid interval classical feature is seen in case of what? In case of your epidural hemorrhage. Next, you have the crescent shape. What does it mean by crescent shape? A moon shaped. Like a moon, a beautiful crescent moon. You can see. So this is a beautiful crescent moon. Like I'm very poor on drawing, don't mind it. Okay, a beautiful crescent shaped findings can be seen in case of your subdural hemorrhage. As can be seen in case of your subdural hemorrhage. And here also edema will be absent and tearing of bridging veins is the reason for this subdural hemorrhage. Your biconvex lens, always remember it is what? Biconvex lens, epidural hemorrhage, subdural hemorrhage, crescent shaped findings you can see, right? So tearing bridge between the veins, very good, crescent moon shape, and elderly and alcoholic falls and slow symptoms over time will be seen in case of your subdural hemorrhage. At last, you have your subarachnoid hemorrhage. Here, in sulci uncystin subarachnoid space will be having the effect. Okay, the bleeding will be there. And here also edema will not be present and aneurysm rupture will be there because of the pressure. And aneurysm, AV malformation are the important causes of your subarachnoid hemorrhage. And sudden worst headache will be seen. And here you can see this bifurcation, which is because of your aneurysm, right? So next, we will go to the next question. A very, 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 very important question in my point of view, and I'm expecting these kind of questions in this upcoming examination. So now tell me, a 65 years old female with anemia receives 3 units of packed PRBC, receiving 3 units of packed PRBC. 2 hours later, she developed acute dyspnea, hypoxia, and bilateral pulmonary infiltrations. Bilateral pulmonary infiltrations on chest X-ray. Her JVP is normal, her jugular venous pressure is normal, and BNP is 150 pg per ml. And she remains hypotensive despite oxygen therapy. What is most likely the diagnosis? Indicating the patient is on, very good, very good. I have received many correct answers. Very good. It is transfusion related acute lung injury. How you are telling it is a transfusion related acute lung injury? Remember, whenever the lung infiltrations is present and the JVP and BNP is normal. Whenever there is a cardiac overload, JVP will be increased whenever there is a cardiac overload. Cardiac overload. As well as if you talk about BNP, your brain natriuretic peptide, this happens because of ventricular stress. Ventricular stress. So if it is going to be 150 pg per ml, it is indicating there is no cardiac workload or no cardiac stress. So it is a condition of transfusion related acute lung injury. In TACO, there will be raised JVP, pulmonary edema will be there. Here also pulmonary edema will be there, but here it will be non-cardiogenic pulmonary edema. It will be non-cardiogenic pulmonary edema. Here in TACO, it will be cardiogenic pulmonary edema. Right? Very good. JVP is increased in TACO. Very good, Uma. So here we will have a quick recap. So TRALI and TACO. So in TRALI, blood pressure will be either low or normal. But in TACO, definitely because of cardiac overload, it is going to be increased. Body temperature normal to elevated and fever may present because of lung infections. But here the temperature will be normal. So what about the chest X-ray? Bilateral chest infiltrates without vascular congestion can be seen in case of TRALI, whereas in TACO, vascular congestions and pleural effusions you can prominently see. So what about BNP? BNP will be low because there is no cardiac stretch or cardiac stress. So obviously the BNP will be low, but because of cardiac overload and ventricular stretch, this BNP is going to be higher in case of TACO. Next is pulmonary artery occlusion pressure, low to normal. Here, obviously, it will be high because of the congestion. Ejection fraction going to be normal in TRALI, but it will be often abnormal in case of your TACO because it is a cardiac overload problem. So response to diuretics, the important management of TACO is what? IV furosemide. IV furosemide is the important management of your TACO. Injection Lasix or IV furosemide is an important management of your TACO, right? But Lasix is having no effect in case of Trally. That also you have to remember. So inconsistent or no improvement after administration of diuretics, but marked improvement you can see in case of your TACO. So type of pulmonary edema, non-cardiogenic, but in TACO it is cardiogenic pulmonary edema, cardiac oriented and cardiac related. And what is the cause? Immune mediated donor anti-leukocyte antibody is the cause, whereas here it is completely because of volume overload. So primary management in case of Trally, supportive care, oxygen, and possible, if the case is so severe, we're going for mechanical ventilation, and you have to stop the transfusion and start with furosemide in case of your TACO. Now we'll go to the next question. Identify the chest X-ray. Now I welcome you all to identify the chest X-ray. Yes. What is the condition? Identify the chest X-ray. Answer in the comment box. Identify the chest X-ray and answer in the comment box. Very good. The correct answer is pneumothorax. How are you telling? Here, this is a not affected side. Non-affected side. This is the affected side. Okay, this is the affected side. You can see there is no lung markings. There is no lung markings. Absence of lung markings. In the affected side, you can see there is no lung markings. And you can see complete blackout. Blackout is indicating, black is indicating air accumulation. So we are diagnosing this ECG, this particular chest X-ray as pneumothorax. And in pneumothorax, you have simple pneumothorax and tension pneumothorax. So in case of simple pneumothorax, what and all you can see is a patient is a case of simple pneumothorax. Okay. A patient is a case of simple pneumothorax. So what are all the findings you'll be seeing? In case of simple pneumothorax, sharp pleural line and absence of lung markings as we see. Okay. Absence of lung markings. Absence of lung markings. Along with that, you can see collapsed lung seen towards ileum. So here you can see the collapsed lung towards ileum. Hilum, right? Collapsed lung towards hilum. Right. So in case of tension pneumothorax, here is where the classical feature you should note. In case of tension pneumothorax, what is going to happen? Same findings which you see in simple pneumothorax, you can see. Right? Very good, very good. Same findings which you have seen in case of simple pneumothorax, you can see. Along with that, mediastinal shift to opposite side. Mediastinal shift to opposite side, you can see. To the unaffected side, there will be a mediastinal shift. And also you can see depressed or flattened diaphragm. Depressed or flattened diaphragm. That is otherwise known as your deep sulci sign. Deep sulci sign, that is a classical feature of your tension pneumothorax. That is a classical feature of your tension pneumothorax. Remember this. Okay. So next, in case of tetralogy of Fallot, what is the ECG what is the chest X-ray findings you will be having? In tetralogy of Fallot, you will be having a boot-shaped heart. A boot-shaped heart. Right? We'll go to the next question. Now identify this particular chest X-ray. Examine the X-ray shown. What is most likely the clinical finding? You can see what you can see. Identify the chest X-ray. You can see the cardiac silhouette where the heart is occupying maximal. Yes. Where the heart is occupying the maximal amount of maximal amount of posterior anterior. The heart is occupying the maximal amount of thoracic region. So this is indicating an obvious cardiomegaly, a very, very important question again. So in case of pulmonary edema, what is the classical finding? In pulmonary edema, what you can see? In pulmonary edema, the patient will be having what? Bat wing appearance. In pulmonary edema, the patient will be having bat wing appearance. In case of pleural effusion, what is the finding? In case of pleural effusion, what is the findings you can see? Tell me in the comment box. In case of pleural effusion, blunting of the crostophrenic angle. Blunting of the costophrenic angle. Blunting of the costophrenic angle. So this is your costophrenic angle. So this is very sharp. In case of pulmonary pleural effusion, what will happen? This angle will be like very much blunt out because of excessive fluid accumulation. Excessive fluid accumulation. Right? We'll go to the next question. Pneumothorax we have already discussed. And identify the ECG given. Identify the ECG given. I request you people to identify the ECG given. Yes. The patient is having what kind of ECG? Yes, meniscus sign is also seen. Very good. Identify the ECG. Identify the ECG, my dear children. I want you people to answer. Hooray, wow, very good. Dashri, Uma, Priyanka, Ankita, very good, dear children. It is Wolff Parkinson White syndrome. Now, kindly list out what are the classical features of your Wolff Parkinson White syndrome. As you can see, the patient is having a very short PR interval. The patient is having a very short PR interval. And you can see the slurred QRS. The slurring in the QRS, that is indicating your what wave? That is indicating your delta wave. Okay, that is indicating your delta wave. And you can see the widened QRS complex. And you can also see the wide QRS, which are all indicating the patient is a case of what? Wolff Parkinson White syndrome. Right? So this delta wave is very prominent, which you can able to easily identify in case of Wolff Parkinson White syndrome. Right? So we'll go to the next question. So now identify this particular finding. What is this ECG is indicating? What is this ECG is indicating? Put in the comment box. This is your, yes, put in the comment box what this ECG is indicating. Identify this ECG. Properly read out. Come on, I'm waiting for your answers. Yes, it is your SVT. Very good. It is your SVT. It is a supraventricular tachycardia. That is your narrow QRS complex tachycardia. Tachycardia. Right? It is an SVT, a raro complex tachycardia. There, the rate, everything, PR interval, everything detail is given. Now identify this ECG. Identify this rhythm. Identify this rhythm. Very good, everyone. Identify this rhythm also. Identify this rhythm. Very good. It is your ventricular fibrillation. It is your VF, ventricular fibrillation. That too, it is a coarse VF, right? So irregular chaotic waveform with no identical P waves and QRS complex and T waves, and this completely irregular baseline. The heart rate is going to be what? 300 to 500 discharges. We have coarse VF and fine VF. What is coarse VF? Coarse VF means large amplitude waves, which is greater than 3 mm, early stage and better prognosis, whereas fine VF, small amplitude waves, and that is late stage, and it have a very poor prognosis. So this is your first degree, second degree, and third degree heart block. Remember, key points only I'm going to tell you. What is first degree heart block? You will be having a prolongation of the PR interval. You will be having a prolongation of PR interval, which is greater than, which will be greater than 0.20 seconds. Second degree, this is first degree, this is second degree type 1. Second degree type 1 or Mobitz type 1 or Wenckebach phenomena. What is the finding, dear children? Here you will be having a progressive prolongation. Progressive prolongation of PR interval. Progressive prolongation of PR interval. Here you can see in first rhythm, second rhythm even more better, even more big, and even more big. That is your what? Progressive prolongation of your PR interval. So in second degree type Mobitz type 2, what is seen? So there will be normal or consistent PR interval. PR interval with drop in QRS, with drop in QRS, with drop in QRS, with a drop in QRS, right? Okay, and this is high-end block where there is 2:1 or 3:1 block. That is termed as high-end form of Mobitz type 2 AVD, my Mobitz type 2 heart block, where there will be, for every P wave, every 2 P wave, there will be a drop in the QRS, which means there is no impulses which is conducting to ventricles. That is the case here, right? In third degree, there will be no association. No association between the P wave and QRS. So these are the classical findings you have to remember. Here you can see in second degree, there are consistent PR interval, but there is a drop in the QRS complex. No QRS. Right here, P wave will be going at one point, QRS will be going at one point. There will be no association between the P wave and QRS complex. So next, identify this ECG. A very ECG already, very easy ECG, which we have already discussed again. This is your what? Yes, I'm waiting for your answers. Yes, very good, Uma. Now tell me, identify this ECG shown in the image. Just put in the comment box what is the ECG you are seeing. What is the ECG findings you are seeing? It is a SVT. It is a SVT. Very good, Shiva. It is a SVT. Okay, now tell me, we'll be very fast. What is the correct full form of the acronym VFAST? What is the correct full form of the acronym VFAST, which is used for identifying the warning signs of stroke? Which is used to identify the warning signs of stroke. What is the correct acronym? Answer? Yes. It is what? B for balance, E for eyes, F for face, A for arms, S for speech, and T for time. First, we will be analyzing whether the patient is properly balancing or not. Eye movements you will be analyzing. Very good. A is the correct answer. Eye movements you will be analyzing, and face movements, any sudden dropping or numbness in the face, you will be analyzing. Very good. In arms, you can see any form of sudden paraparesis or weakness you will be watching. In case of speech, any form of slurred speech you will be analyzing. For time, what is time indicating? Time is indicating what is the time to call an emergency person if the patient is going for suspecting we or the patient is going for a stroke, right? So next, which of the following is a characteristic ECG in patients with hypothermia? In hypothermia, what ECG findings you can see in a patient? This is again a repeated question and the most important question and your NORCET 8.0 question. Now tell me, what is the ECG finding of patient with hypothermia? Very good. Osborne's J wave is an important classical wave you can see in case of your what? Hypothermia patient. Osborne is named after a scientist. Delta wave you see in case of what? In case of Wolff Parkinson White syndrome. Tall T wave in case of your increased potassium, that is hyperkalemia, right? Peaked P wave is associated with right atrial enlargement. So here we will see what is Osborne wave. If you can see the junction of your end of your QRS and your ST segment, the junction elevation of end of QRS and ST segment is termed as your Osborne's wave, and this is specifically seen in case of hypothermia, right? So next question, which of the following drug is administered as an IV bolus to stabilize the cardiac membranes in severe hyperkalemia? So remember, many drugs we are administering in case of severe hyperkalemia. Here they were specifically asking about IV bolus. What drug you administer in IV bolus to stabilize? Very good, Uma. What drug you will be administering for IV bolus to stabilize the cardiac membrane in case of severe hypokalemia? Very good. Calcium gluconate is the correct answer. Calcium gluconate is the only drug which we are administering as an IV bolus in order to stabilize the cardiac membrane, in order to increase the threshold potential of the heart, increase the threshold potential of the heart. So that is the primary point. Whereas soda bicarb, we are administering soda bicarb in order to shift the potassium into the cell. So all these other components shift potassium into cell. This also shift the potassium into cell. Salbutamol, a beta 2 salbutamol, a beta agonist, 2 agonist also shift the potassium into the cell, thereby reducing the potassium level. But calcium gluconate is a prominent component where we are administering it as an IV bolus so that it will increase the cardiac membrane potential and threshold potential as well, right? So the next question, which of the following is true regarding the comparison between your ABG and VBG? Now answer me. Which of the following is true regarding the comparison between ABG and VBG? ABG and VBG show different hemoglobin levels. No, HB is always same. HB is always same in case of your ABG and VBG. HB is same. There will be no changes. Yes, very good, Priyanka. The answer is C. ABG and VBG mainly differ in oxygenation level. This is a very common sense question. So it is very important. Like people should answer it so fastly. Very good. Many people have answered it fastly. So ABG's atrial blood gas, atrial's oxygen concentration will be different, whereas VBG, where there is a venous blood, that is a deoxygenated blood, the oxygenation level will be so much different. On the other hand, HB will be very similar. ABG and VBG shows identical value for all parameters. No, In certain parameters, they will show different values. For example, if you take oxygen, it is showing a different value. Or if you take, in case of PCO2, in case of bicarbonate also, it is going to show a different value, right? ABG shows significantly different potassium levels. Potassium level is going to be same only. There will be no difference, right? The next question. A patient with diarrhea and vomiting, has serum sodium of 150 milliequivalent per liter and the potassium is 30 milliequivalent per liter. See, the patient is having hypernatremia and hypokalemia. So now tell me, what is the most appropriate IV fluid therapy? Now tell me, what is the most appropriate IV fluid therapy? Yes, very good, very good. It is normal saline with KCl, because since obviously if the potassium level is abruptly low, you're going to administer KCl. But the most important other points you have to remember is the serum sodium is high. So in this case, you're not going to administer any form of isotonic solution, right? Here, the most important solution you have to administer is hypotonic solution. So that's why you're choosing what? 0.45% normal saline. Hypotonic solution along with KCl we are administering. 3% is going to be hypertonic and 10% dextrose. Until there is an evidence of hyperglycemia only, we are going for dextrose, right? Let's go to the next question. A patient is presented with the signs of morphine overdose. A very, very easy and simple question. I want your immediate answers for this question. A patient is presented with the signs of morphine overdose. What is the next best nursing action? Yes, come on. Waiting for your answers. Priyanka? No, Priyanka? Yes, Uma. I think it is an typing error, I think, for Priyanka. Yes, yes. So the answer is administer naloxone. The signs of morphine overdose, obviously, the antidote for morphine overdose is naloxone, which is an opioid antagonist. Naloxone is a opioid antagonist, though, so that will be the primary management best action, right? Deep breathing exercises and all will not give an immediate relief for a patient with morphine overdose. Obviously, you should be very proactive in answering these questions. Here, you should not put a very, very declined. See, deep breathing exercises and all coming under very, very least priority intervention. You have to give the best priority intervention. Always remember, this class is completely in English, dear. It is not in Hindi. This is for English students, English audience. Jayant. Sir has already discussed, but here it is completely in English, right? Yes. But all the MCQs are not so similar. So please pay a very good attention. So when administering an insulin injection, what is recommended to rotate? Why it is recommended to rotate the injection site to avoid lipodystrophy? What is the minimum gap that should be maintained between the injection sites? Now give me the answer. Yes. What is the correct answer? Be very clear. What is the correct answer? See, dear children, A, 1 centimeter is the correct answer. That is the correct answer, right? Don't confuse yourself. Not 2.5 centimeter, it is 1 centimeter, right? Remember, A is the correct answer. So which type of respiratory failure is most commonly associated with chronic obstructive pulmonary disease? Now answer me. Which type of respiratory failure is most commonly associated with chronic obstructive pulmonary disease? Yes, dear children. Thank you, Rapa. Which type of respiratory failure is most commonly associated with chronic obstructive pulmonary disease? Yes, very good, Jayant. It's type 2 hypercapnic respiratory failure. So a person is diagnosed with COPD and started on non-rebreathing mask of 15 liters per minute. Even though after administering with the help of non-breathing mask with 15 liters per minute, the patient is showing shallow respiration, which is the patient is on hypoventilation. The patient is on hypoventilation. So now tell me what will be the most important next step management. Very good. It is initiating a BiPAP. Always remember in acute exacerbation of COPD, of your COPD, the primary management is first is non. If the patient is stable, if the patient is conscious, and if the patient can cooperate with you, the primary thing you have to do is BiPAP, that is non-invasive ventilation. Then only if the patient is totally unstable or collapsing, then only you will go for mechanical ventilation. So mechanical ventilation is not the next step because the patient is going for shallow breathing, but there is no any evidence of hemodynamical instability or unconsciousness, anything. So you should choose always non-invasive ventilation. So this is a primary NCLEX rule also. Okay, it is a primary. See, it is an NCLEX rule. Less invasive, always in option, choose less invasive over invasive. Non-invasive, less invasive, or non-invasive over invasive. This is an important NCLEX rule you people have to remember, right? Excuse me. Yes. What is the rhythm? Identify the rhythm. Identify the rhythm. It is showing a narrow QRS, irregular RR wave, RR interval, a very narrow QRS, irregular RR interval. Yes, the answer is on. Irregular RR interval. Yes. Yes, yes, yes. Very good. It is atrial fibrillation. The answer is atrial fibrillation. See, Priyanka, we have a page. I have a page in the social media, that is Nursing with Priya Balan in Instagram. You people have any specific MCQs with which you have doubts, you can forward me directly into that page. I'll be giving you an instant answer over that particular page. I'll show the details of the page. That is Nursing with Priya Balan. So you can directly contact me to that page if you have any form of doubts or any form of query you have. Directly, you people can connect with me. So the ECG wave which is shown is atrial fibrillation, right? Yes. Now tell me which of the following ABG parameter is most likely to be falsely elevated due to delayed refrigeration of the sample. Testing your clinical skills. These questions will test your clinical skills. Okay, dear. I'll share, dear. I'll share definitely. Yes, very good. I want the answer. See, the answer is partial pressure of oxygen because of cellular metabolism. Listen, children, when I'm delaying the refrigeration, what happened? The mismatch of environmental pressure and the atrial blood pressure. Atrial blood pressure will be increased, right? There is high partial pressure in the oxygen, in the room air, right? There is a high partial pressure in the room air, that is around 150 to 160. Whereas if you take about your atrial bloods, oxygen, partial oxygen pressure, it will be just 75 to 100. So when there is a delayed refrigeration, the primary happening is the change in the partial pressure of oxygen because of cellular metabolism. So remember, when you are delaying the refrigeration, the important effect is going to be on PaO2 because of pressure difference in the room air as well as in the collected blood sample. Yes, very good. So now let's go to the next question. While performing a radial arterial puncture for ABG sampling, what is the ideal wrist angle for proper atrial access? Very, very simple question. You people know that whenever the patient is going for any form of approach through radial artery, either it is a PTCA, either it is an ABG, very good wrist extension of 30 to 45 degrees, correct answer. So they will be maintaining an wrist extension. Why this wrist extension is done? In order to make the radial artery to become immobile. It should not wobble while pricking. It should become immobile, and also to make the radial artery to present superficial, we are giving this wrist extension of 30 to 45 degree. If 45 degree is present, that will be the best answer. The best answer is 45 degree because lot of research studies supporting that 45 degree is the most optimal position for positioning the wrist for radial arterial insertion of ABG or any other sampling. Now tell me, which condition can cause pseudo hyponatremia on lab testing? Now tell me, which condition can cause pseudo hyponatremia on lab testing? What does mean by pseudo hyponatremia? It is false hyponatremia. What is mean by pseudo hyponatremia? It is false hyponatremia. Now answer me. Very good, very good, very good. High lipids and proteins can cause false pseudo hyponatremia. Right? Why? In plasma, it is 93% water, 93% water, and 7% is solids, where lipids and proteins are there. Right? So here, when lipids and proteins are higher, this is going to cause the water infraction to get reduced. Thereby, the patient will go for false hyponatremia. So if there is high plasma water, what will be the finding? If there is a high plasma water, the patient will be having true hyponatremia. The patient will be having what? True hyponatremia. If the patient is having high glucose, what you can see? That is hypertonic hyponatremia. Hypertonic hyponatremia. Low osmolality seen in true hypotonic hyponatremia. It is seen in true hypotonic hyponatremia. Right? Yes. Let's go to the next question. Which tuberculosis treatment category has been removed from current guidelines due to poor outcome and resistance concern? Yes. Now tell me the answer. Quickly put in the comment box which particular category has been removed from current guidelines. Fast, I'm waiting for your answers. Category 2 is a retreatment regimen. Yes, very good. Very good. B is the correct answer. So where streptomycin is added. So what this is doing, this particular streptomycin therapy in category 2, which is used for retreatment for relapse case when we are giving, this is going to cause multi-drug resistant TB. This is preceding for MDR TB. So that's why this category 2 is removed. That's why this category 2 is removed. So whatever patients are coming in relapsed cases, what we are doing DST, that is drug susceptibility testing. Drug susceptibility testing. And we are testing individually like what drug they are susceptible and what drug they are resistant. Based upon that, we are giving the care. So what about category 1? Category is still used for new smear positive patients. New smear positive. positive patients. What about category 3? Category 3 was previously used for less severe cases, but now it has been merged to category 1. It is merged to category 1. MDR TB regimen, it is still used and it is guided with your DST testing, right? Yes, the next question. A patient is suspected to have a bacterial meningitis. Bacterial meningitis, which of the following investigation is most critical to establish the diagnosis and guide for early management? Obviously, the patient is a case of bacterial meningitis. The primary concern is to do a blood culture rather than all the serum, calcium, glucose, and potassium. So primarily you have to do the proper blood culture and you'll have to evaluate what is the organism responsible. And based upon the organism, we have to plan the antibiotic therapy. The most important thing you have to remember is blood culture should be always done before starting an antibiotic therapy, not after starting an antibiotic therapy, right? So blood culture is the correct answer. Very good, Naveen. Very good, Nasrin, Ankita, RTC class, Shiva, Ankita. Very good, very good, very good. So let's go to the next question. What is the recommended maximum rate of correcting? A very important high yield area. This is where questions can come. Recommended maximum rate of correcting serum sodium in patient with chronic hyponatremia to prevent osmotic demyelination syndrome. As you all know, the rapid correction of hyponatremia with sodium can lead to osmotic demyelination syndrome. Very good, 8 to 10 milliequivalent per liter over 24 hours is the correct answer. Or else the patient will be going for osmotic demyelination syndrome, which is a non-inflammatory syndrome. Okay, which is a non-inflammatory condition, which is specifically going to affect your pons. And this in turn going to cause various signs and symptoms, which includes your paraphyresis or quadriferesis weakness and dysphagia, dysarthria. So these kind of symptoms you can see when the patient is corrected with the rapid correction for sodium. The optimal thing is whenever there is an MCQ, not more than 10 milliequivalent per liter over 24 hours. But if you want to be so standardized in it, always remember for 24 hours, it should be less than or equal to 8 milliequivalent per liter only. If you're going to plan for 48 hours, it can be what? It can be 15 milliequivalent per liter, not more than that. Right? Yes. The next question. A patient is presented with confusion, lethargy, and blood pressure is 180, 110 mm of Hg. Heart rate is 110 beats per minute and SpO2 of 85% and respiratory rate is 24. The patient is exhibiting tachycardia, tachypnea, and the temperature hyperthermia. And what is most likely the diagnosis? So whenever you see conditions which is exhibiting tachycardia, hypertension, and the patient's respiratory rate is also increasing, the temperature is also increasing, then the patient is a case of sepsis. Right? Closely correlate your answers with the what? With the question. The most important thing is always remember 2 distractors you will be rejecting so easily. Rest of the 2 will be so confusing. There you have to use your practical skill and your learning, your this much of hard work you have to use there. And the most important thing I would like to tell you is never get any form of anxiety, any form of fearful, kind of so anxious once you sit in the examination hall. Be very confident, be very polite. Remember, this NORCET 9 is not only your destiny. You have various other options, but this NORCET 9 is where you put all your hard works in. So these hard work should definitely pay off. But don't hinder your hard work by having excessive anxiety attacks, anxiousness, fear in attempting questions. Be very simple, be very calm, approach the paper so casually, be very cautious about negative markings. while you're giving the grand test, which is available in NNL, be very clear that you're going to attempt it as such. It is an actual examination, so that you'll be having a good trial before going for the actual examination. Give all the grand test. Don't overburden yourself. Don't stress yourself. You have done all the hard works behind. That is going to definitely pay off for you, right? So be very confident, develop a very good self-talk within yourself, be very confident, and you go and attempt the test. Everything is in your hands now, right? But never ever become so anxious, because anxiousness will make you to leave some important points in the stem, leave some important points in the distractors. So be very, very clear. Whether you have to see, definitely you have to see. Whether they are asking about except factor, not factor, true factor, false factor, all the following are true, except. See, at last they will be putting the water or putting that word, or in between the question, that word will be buried. That is where this is the trap. This is a competitive examination where n number of students are writing. They want to scrutinize all the tactical students who are so confident, who are very, very confident about their learnings, about their knowledge. Those people are those people are whom they want. So you should be very, very tactical, very, very attentive. If you want to pay a very good attention towards the paper, you should not be anxious. You should be very cool in attempting the paper. Be very cool. Whatever, if you're cool only, all the things which you studied will come to your mind, or else you will be wandering here and there. You'll be feeling excessive stress, and once the question is done, leave the question. Last question you have attempted, because you have very limited time. This question I have spent, oh my God, did I answer it correctly? Did I answer it wrongly? Don't have those second thoughts. That question is done, that is done. If you have time, go and do a recap. But while attempting the next question, don't think about the previous question. Concentrate on that particular question. Concentration can gain more knowledge, or more chances of tricking the correct answer, right? So let's go to the next question. Which of the following condition is a pulse deficit typically observed? What does mean by pulse deficit? Pulse deficit is a difference between heart rate and your radial pulse. Or specifically, you can tell it is a peripheral pulse. When there is a difference between your heart rate and the peripheral pulse, that is termed as what? Pulse deficit. The correct answer is atrial fibrillation. Very good, Priyanka. So why this pulse deficit is usually seen? Why this is seen when not all the ventricular contractions are so effective, so that it is reflecting in the peripheral pulse, right? When all the ventricular contraction is not that much effective, in that case, it will not properly reflect in the peripheral pulse. Thereby, you can see pulse deficit. The most important thing is, in case of atrial fibrillation, you can see pulse deficit. These are all the classical feature. So in that also, you have to remember, apical pulse will be greater than your radial pulse, because of effective ventricular contraction is not happening. You cannot feel the pulse in the peripheries, right? So that's why your apical pulse is going to be higher when comparing to your radial pulse. So this particular deficiency is termed as pulse deficit. So this is seen in case of atrial fibrillation, along with other conditions such as your tachyarrhythmias, your premature ventricular contraction. In these conditions also, you can see this pulse deficit, right? So next question, which condition is depicted in this image? Now tell me, which condition is depicted in this image? It's very, very easy. Psoriasis, you will be having silvery white patches. This condition is very, very easy. Yes. Answer me, dear children. Very good. Steve-Johnson syndrome is the correct answer. Yes. So this is classically indicating the Steve-Johnson syndrome. So as you all know, Steve-Johnson syndrome, your SJS is an important syndrome which is happening because of, most commonly because of antibiotic reaction. So what is the primary antibiotics which are responsible? First is your penicillin, sulfa, other drugs which includes your phenytoin, any other drugs, phenobarbital, NSAIDs can also cause your Stevens-Johnson syndrome. Other syndrome you have, when Stevens-Johnson syndrome is progressing, you have another syndrome that is toxic ependymal necrosis. That is your toxic epidermal necrosis, right? Necrolysis. That is 10. Your toxic epidermal necrosis. Necrolysis. So when this condition is proceeding more severe, that is your toxic epidermal necrosis. For example, here, if you talk about Stevens-Johnson syndrome, only less than 10% of the body surface area will be involved in this particular erythematous base formation and erosion formation and puric macula formation. But here, in relapse case, for example, in relapse case, this means overlap. When Stevens-Johnson syndrome and toxic epidermal necrosis, they are overlapping. While overlapping, what has happened? When they are overlapping, there will be less than 30% of body surface area is involved in this erythematous lesion formation. But when the patient is going for toxic epidermal syndrome, actual toxic epidermal syndrome, a very, very prominent condition where their involvement will be greater than 30% of body surface area will be having this particular lesions. So it is very severe condition. So most commonly, these conditions are happening because of drug therapy. So as we have discussed. So next question. Which of the following is not included in your SIRS syndrome? SIRS score. What is SIRS score? Tell me in the comment box, what is SIRS score? SIRS score is your systemic inflammatory response score. Sorry, systemic inflammatory response syndrome scoring. So here you can see the findings are temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, paradoxical conditions. Heart rate will be greater than 90 beats per minute. Tachycardia, respiratory rate will be greater than 20 beats per minute. So here the most important MCQ point you have to remember is in Q-SOFA score, the respiratory rate will be greater than 22 breaths per minute. Right. So you should not confuse. Specifically, 20 breaths per minute is very specific to your SIRS scoring system. Right. So white cell count will be greater than 12,000 cells per mm of cube and less than 4,000 cells per mm of cube either. Right. So any two plus document the site of infection. But what is the finding is if any two is present, you are diagnosing the patient as a case of SIRS. So here heart rate, yes, it is an option. They are asking what factor? Not included. Which of the following is not included? They are asking. Systolic blood pressure. No, there is systolic blood pressure is not component of your SIRS. So that will be the correct answer. Right? So temperature, respiratory rate, everything is a component of your SIRS. Right? So the next question. What should be closely monitored when administering digoxin? A very, very easy and simple question. What should be closely? Very good, very good, very good, very good, Prabha. It is a serum potassium level. Now tell me, hyperkalemia or hypokalemia will lead to digoxin toxicity. Hypokalemia or hypokalemia, which is going to lead the patient for digoxin toxicity. Answers, please, in the comment box. Either hypokalemia or hyperkalemia is going to lead the patient for digoxin toxicity. Very good. See, remember, hypokalemia will lead the patient to go for digoxin toxicity. Whereas if the patient is going for digoxin toxicity, he will go for hyperkalemia. Digoxin toxicity the patient has attained, then the patient will be exhibiting hyperkalemia. Why hypokalemia will be leading for digoxin toxicity? Hypokalemia and potassium as well as digoxin is having same friends in binding. When potassium is not binding, when potassium is very less, their friends are very much free. So what digoxin will do, they will go on attached to those friends, right? So what will happen? If potassium is in the normal level, everybody will be having equal friends and they will be sharing and carrying. When potassium is not there, digoxin will overperforming and establish more friendship, right? So what will happen? Hypokalemia will cause digoxin toxicity. But paradoxically, you also have to remember after patient is going for digoxin toxicity, the patient will go for hyperkalemia, right? The most important finding you have to remember. And the most important thing, additionally, you people have to remember is whenever you are administering a digoxin, always manually the patient has to be monitored for the pulse rate. When it is less than 60, digoxin administration is contraindicated because it is a rate controller drug. When it is administered, the patient will go for severe bradycardia. So it is an important note. So at last we came to the end of the session. So it's been a very long class, and I thank the children who were with me for a long period of time for carrying and sharing knowledge. So this kind of patience you actually need while preparing for any competitive examination. I wish you all the best for your upcoming NORCET examination. For Plan C English subscribers, we will be having a separate meeting, and we will be expressing. I'll be coming with a test taking strategy videos and all. So I'm so happy for giving this session, and thank you so much for being with me for a very long period of time. And I hope I have given you a very good insight and very good knowledge on this particular session. So for people who were asking about MCQs and their queries on scientific queries of AHN or pharmacology, you can directly message me through this Instagram handle. So it is, I'm handling it personally. So you'll be getting an instant replies over that. Kindly do a support and follow me on my Instagram. And if you want any kind of scientific queries, and already all the scientific contents are uploaded in my page, which will be very useful for you for the upcoming NORCET examination. So thank you so much. Here where we are ending the session. Thank you so much for watching.